started as possible to get as much attention as we can. It's Arlene and negative breast cancer. To the group in the big room. First is being claimed. This will be and it's beyond birth. So this after Recurrence and they can link to it. Bathrooms are down the hall and for we're going to be text question and pass at the end. Information up on the screen. Keep your questions. Dr. The information, and then we'll put up the text number, and you can text that. Do if they don't want to text or don't. On a piece of paper, if your phone. As I said, I'm with to tell you about some things. First of all, we have a webinar conference specifically African American women and it's happening. Do you know the time? It's recorded on our website. So if you miss it, and which is this is our here. Team. Have participated in that. It's a grassroots just for us. Country in other countries we've had awareness events, fundraisers, a day we just come to and spread the word about triple negative. Go to our website and web and sign up for events beginning now. So any more information about now I introduce our Cristofanilli, so to have such negative breast cancer. And a little bit about Dr. Cristofanilli is a renowned breast cancer researcher and clinician, and director of the Cancer Center and Thomas University. 20 years, deputy director of relational research. Prior to Jefferson, Cristofanilli was chairman of the Medical Oncology Cancer Center in Flower Clinic. Before that, he served as director of the Morgan Welch Inflammatory Cancer Program and Texas Cancer Center in widely research and treatment for breast cancer, an aggressive form of breast cancer, cells, lymph vessels in the recognized expertise, development of prognostic markers in primary and metastatic breast improve cancer patients, focus and gene therapies, and bridging the gap between the bench and smarter way. Of team disciplinary approach.
Nice section is nice. Here, even placement. Research in triple-negative breast cancer that some overlaps with inflammatory study breast cancer will become apparent during my presentation. Fernanda couldn't make it, as you know, but she was to provide us, and I just tweaked it by just to make clear that could be integrated, but most of the presentations to her. Trying to see what we're learning in ALP. What we're going to do is simple on the definition. Risk factor. I will update on that and treatment options for triple negative. I think what we learned alternative for clinical trial agents for the way in general in is much used and definition. Okay, everyone for some our breath too. This, as you know, the positive over the years. Now just cells as it's called triple negative biology. And that's with implication. The 30 have 15 even large up to 30% number of triple negative breast. And unfortunately, we still as a before for treatment early phase but effective particularly negative, as you know, bevacizumab and talk about. This is the publication 2001. Was not only positive, negative is different type 5 of 4 more. So this is filing, then put together regional expression of ER groups of they have also an outcome. The same systemic treatment, but didn't have the same benefit. Clearly, this is subtype in the breast cancer. The base and they have a worse outcome. R2 is a gene. This patient patients have more. The study is very, and the basal like now there are two to identify this is a the therapy for this and now the survival is different, but include most of the triple negative. When we look at the base, in fact, the cases tend to is 75% or negative fall in basal. Few actual molecular to luminal B. We don't have time. Certainly, the for which this breast cancer different cancer stem cells. The most in general P53 is a is resistant before if his cells will continue to proliferate and so associated with to very much used in breast cancer. And of course, sometimes is also be associated. So many of the hereditary cancer, BRCA, triple negative risk factor women and Spanish for appears BRCA1 mutation. The majority of BRCA in fact 65 triple negative CA2. We have and triple negative disease. The percentage of a young woman with triple negative for additional breast cancer for ovarian cancer. Of course, it's surgery. This is important. Mastectomy or not. Population 10%. Familia is 50%. The discovery means the post of breast. So the more overlap without knowledge is involved with the creed. So one cancers, obviously, because of the family, two knows see many times with cancer on, and then they have a breast cancer age. This women, they may have syndrome. Cancer, class cancer, colon. That goes from the to the daughter, and of course, specific groups that are in higher is that. So we know that the obvious just what you do for a predisposition is high developing a treatment, so most likely the thing to do is start prophylactic. For the patient develop CA1 and 2, we have not information in the number of looking at the sensitivity of the drug. Are the be benefit more, but the direction and FDA approach. We say is the knowledge regarding to hereditary condition. Opposed to breast cancer, this approach just recently, 6 weeks ago, B2 gene has been associated has been a study that show clearly this indicates you have certain mechanisms that reproducible are very important, maybe providing satisfaction. So now, hereditary condition, general allow the treatment. So when we presented with a new breast, we're going to look at the tumor side, that there are distant metastatic staging to stage diagnosis, presentation. So the treatment is palliative, and for the others, the standard biomarker right now set hormone with chemotherapy, biotherapy for HER2, and there are many. Not talking about that for the HER2 ER people to chemotherapy. There are diagnostic tests can be to how these specimens are useful for treatment. This is for immunity-ish standard, but there is a possibility for, and I'll show you at the beginning. In fact, the possibility. 3 breast cancer expression of ER, but also disease. We can look at videos, so some therapies, ER positive disease. When you get and there is a residual disease at the end, residual disease to see which is resistant to treatment and maybe other treatment after disease. It's important. So genomic is later. So on the side, we went at so neoadjuvant is down before surgery, and typically patient unresponsive require a down agent. The treatment to prevent recurrence. Lately has become more and more, as you know, where we can develop new drugs. This is sensitivity. Assess upfront how the response curative that have a way to see. Sometimes the effect is different. To target we put in different phases, and of course, our palliative treatments are improved. So the palliation can be good for many years. Which are the treatment for cancer? Of course, the treatment are pretty much the treatment, and in the past showed especially when interested in based are the backbone, even for negative, even though there is so important. The order really does adjuvant diffuse types coming from the MD Anderson show that if you give before, you probably have a just the effect on the tumor and the value of the factum, there is no effect on the survival on the treatment therapy in tumor. Something in abbreviated fashion. This is the systemic primary breast cancer. First therapy reversing therapies for the food, and I want risk as we mentioned, an during patient tumor is completely gone at the time of pathologists look at you see that in both cases adjuvant have immediate tumor colon the time should not go directly to because there would be an issue with local recurrence in their therapies. So something that we need to case. So this is an example of advanced tumor. I'm sorry. This is a tumor that it took a time to this point, it was neglected. It did grow in just a few weeks and was and really the same size. You need to really identify difference. So this look, there were three therapy at MD. Look at the pathology the day of showing essentially that the triple negative patients do well if they are CR, they do well. And you can imagine that having therapy, we don't have the therapy left is really aggressive. So the goal is only to find, there is for now responders, learn from can triple negative cancer group. The group of patients, eventually we have recurrence part negative breast cancer. As you know, the first 2 or 3 years, because that's where most of the ended up in the vision, lungs, liver, the brain. By one of the 20% chance, some cases even less common in the. I think we have a disease confined to the bone for long. You want to do a biopsy of the metastatic site for an disease, because we know the triple depression or ER is surprised because there's some that ER particular in the bone. So that up to 20 to treat disease where we only chemotherapy. Look at so chemotherapy in the metastatic setting. You know that this is just a list available for treatment, but we have to do much. So you sense if you're using, and of course right now many vaccines, and we don't the bottom of the list. The question is how do select how to use. Just they feel pretty good about it right now. We have select. How do you know is the symptom? I think there are a few other times be useful for population. Just participate in a clinical trial to develop for negative. And we'll talk about what now. So far, I think treatments that is what we learning is that putting more effort for triple negative breast ER negative to negative disease, but is genetically unstable. So if you evaluate the DNA negative disease. There is many other disease. This means that this disease continues. We can progression of this therapies with not a the fundamental process, genetic character and instability. Stability type of very naive to believe that there was only one type. First of all, because clinical patients have to respond very well to everything, and for some others not. In the middle, we have the majority of the population. At the expression profile that there are genes that classify subtypes. So this negative two. When you look at the expression in this gene, you start all knew that so now there is a delay. About there is this is obviously hope for a future of immunity that the triple negative. Fact, there is this touch the to because I have a mechanism of chemotherapy agent, and then the best group is probably the IR receptor is expressed group, because so there are some which we where we have developed cells compared to the overall use with and effective in chemotherapy in a more judicious. So this is a paper that types can lines and in vitro and to the different respond to androgen receptor for the androgen receptor. Actually, don't need that molecule that attack that we don't have time. So the implicate category of different pathways are opportunity for the better drug deals for improvement. I think they all one drug for everyone. If we give this chemotherapy to every breast, the same benefit. That's multiple. Fraction of the fact that they have some others fall in therapy before negations. There are a number of studies in neoadjuvant that continue to explore the, I think, the neo mentioned. You can test analysis and some the bevacizumab metastatic chemotherapy appear to be pathological complete. So how to do everything in response? And agents is the and this is something that we also contribute to. The case study was also a study that these parts are particularly in the breast. And of course, this comes from the rise of obesity. Are bleeding, hypertension, and so forth. Bevacizumab for that reason is certainly effective for women. The drug is not available in for more. I mentioned looking at the mechanism missing RBA1 or 2 mutated PC or the combination used a very high women that have RBA1 mutated have the be aware to get percent use this combination include of course the mutation. Probably the drug breast cancer with anthracycline, which is the pathological second. We just say that we have a neo study where after the phase the platinum platinum liver phase 3 look as you see nobody's giving the just in a line to increase unstable cells with a carboplatin. If you PARP inhibit this from the previous metastatic disease. Once again, probably population by this agent target not only for the also for negative in recent some affected and then pathology metastasis is to obtain I mentioned every time that we can to confirm the standard. Important to make assessment of that particular recurrence is given opportunity for actually a paper that we published as a case inflammatory breast cancer patient. Immediately you have a number possible enough for this patient. First treat a combination of pattern difficulty that could benefit. Then we finish the treatment and we include the shadow response after 6 lines. You see the PET I think the sprint the the face. She had a symptomatic improvement. So this is this mutation was a driving mutation. The therapy was a probably fine if it was for advanced can find a therapy that can be. Of course, something that is as much as possible, especially for patients that have resistant disease. Residual disease is with the study disease. They have shown preliminary study that the patient that you find that disease after neo, the same mutation that you find a recurrent disease when you get a biopsy. It's time the mutation driving before we do anything different. What can we do? It's a question. There are the mutation but this information is actually able to change the chance. Like, we need your effort. Your therapy the immune promising, not only also for triple-negative breast cancer. They seems extremely promising. So big negative breast based on the type triple negative to the right population with and abnormal combination with chemotherapy. And there are still an activation proof ER disease or ER negative area where some of these three can take advantage. Of course, how to modulate inflammatory response in a different setting. As you know, the blood is a and the other thing is the blood readily available every time we want. you look at the DNA of the tumor and what I mutated that came about these cells for time now. It's been 10 years since when you are to identify in the peripheral blood, these cells are informed setting. A patient have more. So this patient in fact triple negative. And there's treaties are the worst. But so the other group, triple negative belongs to the. And the question, we know that having is an indication in that we start to find out that these cells that this is the triple negative, in fact, behave like a triple negative disease, even in the on the tissue. This is a very, very dynamic. With regard to the one question, retrospective, not worse, but do therapy versus a single agent. You do better. Well, there was a patient it is do a little bit when they have combination selection based on and this were not necessarily chemotherapy. Other thing is one this will tell us that this patient have more than metastasis only cannot be cured by visual metastasis and do what? We have to be careful in developing for a group of patients. In the tissue, we can identify cells that are with a mutation. Cell with the fraction of patient between % of the cells positive. We do it as information. I think we're and try to in a more so that's what we do. Upon the times of and this tumor actually here positive going to be treated because either out for patients 50 she was she's doing well. New tools evolving biology of triple negative cancer. different phases of clinical trial. Important. First of all, the care placebo. If you are in the phase 3, if you use a study, at least the standard. We have coming up one major triple cancer phase 2 randomized study. This is institutions target together with therapy. So if you standard arm, as you will, if you participate, 50% is women, will to be the future of negative breast cancer patients. Not improve combination of drugs. Sometimes when we combine two ultra toxicity, this is the phase 1, but also what the triple negative is new. The new drug developed specifically for triple negative disease. Sometimes this is it is already now. Phase 2, you look at the improve the response rate, even though response are very but the progression accurate. The progression that is important. Of course, the phase, everybody would like to participate in, but how many? Why participate? Well, negative patients, there is not really many studies as I show you. So you may ask this new drug. Of course, moving is very important to a few of the patients. The more we research the criteria of participation to be a response. Phase 1 trial, 2 to 5%. Molecular this goes up even 10%. So that is probably a better chance. Study if you're going to be assigned to, but you have a chance. You have to try to look for. Many of you have been going to the web and trying to figure out where time biopsy. I think all is worth it. For if they don't offer to you anything, if they just negative, second opinion, you want to know what they're available, what can be instead of just standard. You can every information for the triple negative foundation. Certainly try in your time the most. In regard to mentorship, these are the local groups, the triple negative. You already know that. Just important. Disease. Really talked about the research. When you understand it, is life-saving life in the right, you know, this is different types of develop clearly what this is medically unstable. Changes we can count in the blood. It is mutative, easy to target, but certainly and know this with every the disease. We have technology. In the future, you know, a lot going on in understanding therapy. Can prescribe without understood the disease. Biology intervention and we develop a really thought plan. The first jumping into next therapy, probably chemotherapy for metastatic so, and we will know. So thank you.
You'd like to sit down. We by text. Here is the so please questions. Is Kendra in the room? Kendra? Okay. Arlene is going to pose the first, and if you do not text a paper or pick them up, and maybe Haley will help out those. But first question, and start to read your question. Them to.
If anyone has down, I can start with one that's written.
I'd like to thank you for a wonderful presentation. It was very detailed and there's some confusion, I think, about how from negative to positive. Could you on that and what that means for treatment?
Patient have the possibility to have estrogen disease. Remember, first is always not every. It's quite possible that there is very heterogeneity. After the old treatment, some of these metastatic aggressive, certainly I think they are estrogen positive. So in some cases, yeah, to do chemo, the option was a triple negative ROS period because these women were not developing brain metastasis affected with triple fatty are positive. Selection disease process you always or bomb metastasis of course can be treated more with endocrine therapy.
Thank you. Therapy, how high is the risk of higher than the breast cancer?
Yes. Depends, of course, on the size. So if you had the neotherapy, you had a high risk. If it was from the basal negative has risk of recurrence. I'm talking about the 1 centimeter. That we're talking about larger tumors. Compared to have endocrine therapy, 10 years, tend to target with or without any. The triple negative enough. There is a fraction of cells that are persist after the adjuvant therapy. There is a higher risk, but also therapy after.
So this goes along. The post-diagnostic test.
ASCO guidelines in of what when you have a patient. I personally markers for disease. I think we adjusted for our negative risk of recurrence actually a year because we know this is the type of disease that we recurrent not seen for a long time, so adjusted based on all your risks. So if you are very risky, respond. I go for everyone just to say let's watch and not doing anything. At 2 more months. There is this area, there's where we can detect the tumor blood. Women have they have a high recurrence, become more and more used. Being a recommendation, insurance is a, as you can imagine. I think that's to be comfortable not to bank when there is a high risk condition.
It's a question about what you have. What are the questions, doctor, to give they can take back doctor so what they're
There are test-based profile blueprint for it. With some impression of estimation, I think there is more and more trying to do this genomic test. Patients are ERP additive to help you planning for the next treatment. Patients really need to. There are standard commercial tests. The foundation been around for 2 years. Very useful.
We have some questions about BRCA testing, since there has been a new test to go to ask them to retest.
Well, I think on the risk, strong family, I think there are now other genes that can be tested. There are genes associated with increased risk. But it's possible that this can be used.
Thank you. Yes.
They test for NDC. Yes.
They actually do for many for in this year. It's just that don't use Septin for looking at the effect of Septin. Just that it's not effective because conditioning with certain radiation.
Perhaps she ask a for doctor about testing.
Well, actually, academic institute.
With who determines if you
have two Septin, but to indicate there will be a selection for. Sometimes we have with insurance because found to be triple negative, and now it's becoming easier and easier because we understand that this is clinical practice now.
The breast cancer put type cancers, liver,
Only if you have a genetic predisposition. So otherwise, no.
You know, a question, you know, really want therapy, some pipeline therapies for triple negative.
Being developed now, the one going into the specific, but there are some alterations at template. I mentioned the stem cell. One of these, so notch targeted therapy developed particularly in triple. Targeted therapy. The beginning of this, we test the T, see if there is very just sensor to be without any understanding biology for the stem cell targeted therapy, because people already eliminate the one that and the other new metastasis. Every therapy is overall to also eliminate able to other metastases. Stop the process.
One is asking, is the future of for TNBC?
Well, I don't because we did those chapters used first line bevacizumab. They have in terms of survival, the health and pays for it. It's unusual because it's most system in the drug. As you see, there are maybe different styles between Europe and I think pragmatic, and we wanted to see advantage. Overall, I think there are the development looking for the drug to everyone that we keep doing in drug development. So some simplify between two as a not because the drug is not treatment. There are many there. We just need to.
is what to get that from your doctor?
Well, if you are surgery or biopsy available to be tested for. If you have a recurrence, get a biopsy. You want to make sure that this biopsy is analyzed for mutation protein expression. That's information treatment. And some difficult to use the blood for getting the. So I ask doctor is not, as I told you, to look for a second opinion.
And that doctor, if you go for a second opinion, can that doctor?
Yes.
Get it through the.
Yeah.
Great. Do you genetic testing again? A testing question for all NBC patients?
I think that we're in a situation where there were more genetic testing offered to a lot. This would be triple negative. If they're young, selecting groups and of family for some cancers. Obviously, cancer first, because this, at the end, may you to save resources. No problem. Hopefully, will not be a push and over to know for a larger fraction of patients.
Thank you. Effective and reliable when negative readings.
Well, yes, I mean, tumor markers are interesting enough. And so argue against new introduction. Markers. The tumor markers mean they well shown months. Such an effective. I think we have a, but it's the best we have. You see one of them very quickly, so to look for this evidence.
Post-surgical or very
the decision when you in the context of a multidisciplinary team, very carefully. If there is lumpectomy is borderline, I mean, remove all the side area that's resected. I think is clear that maybe mastectomy will be the option. Sometimes surgeons jump back to them because women play this. the chance to develop another primate. Aware of that, and what you do, guys, more and more. If there is no difference between like certainly there is no impact, but mice because of margins, DCIS, and genetic conditions may be different times.
There's been a number of things coming out looking at prophylactic. Maybe they're not as once. How does a woman go about the or some of the key she can enter?
I think distinguish between event to come in the first prophylactic cancer. Prognosis can be affected by the. So when I have, especially HC1, 2, I think mastectomy. You know that disease is very perform prophylactic impact survival of these women. So it's always a careful assessment of other mastectomy and surgery. Some left behind. Some sparing mastectomy. Some tissue risk. It doesn't completely eliminate the risk of breast cancer, up to 2%.
Include tumor each 3-month appointment.
Well, as I said, it depends on the risk. Doing everyone. If you had a response that we don't and not, and I do it.
Well, let's see. This is just the questioner triple negative breast cancer is found mainly in men. Other kind of, should they get testing also? And some are concerned.
Yeah.
I'm sorry to interrupt. And some are children.
There are the standard for has to be becoming more to test these conditions. Doesn't mean that there's, as we say, this for testing. Don't forget, that's pancreatic cancer. Look at definitely for a genetic counseling to the family disease.
Used a difference between hereditary cancer.
Yeah. Hereditary is when generally identify genes that response for the development of the disease. We have a number of individuals with the same disease, so any mutation. So you have a predisposition. We have not pinpointed. Eventually, we're going to find genetic risk and
what type of exercise she can do since her surgery, and what would you do for pain?
That's we're talking in general. You want possibility to show the size, risk, recognize pattern. So more exercise to lose that. And some of the chemotherapy will eventually go away. It's tricky because surgical site, and that could be for that reaction with pain medication, pain. So this type of pain, I think you need to talk to your patient about that. If this is you, that's obviously something that with possible.
Any pain, you should talk to your doctor specific. Right. That one about use T.
What complication from chemotherapy are not as common as we used to be in the affecting complication with therapy. So that is has been focused on research more with cardiologists in academic institutions. We don't the IDOs that we used to do in the past. You can use Rubicin. Overall total dose. There is no major cardiovascular course. Cardiovascular with hypertension. There are not included equal. It's a matter of discussing with your physician. What?
Thank you. Many questions about recurrence. Are in recurrence?
I mean, a few years ago, the retrospective study database showed that women who were overweight and obese had a higher chance when at risk. So that's an inflammatory. Now, the higher chance of visual metastasis. So, and enough chemotherapy up front based on body surface weight and fat. So obesity is a pro-inflammatory condition, also in these patients. Clearly changing the try to lose over because
okay. Scans after they're done.
General now, I mentioned that disease that I see in the clinic develop a of tissue lymph node the recurrence cannot be detected them or even a CAT scan. So we try to use PET as a follow up for but some is very early on. Cannot say that this had an impact. Recent publication that we had when we opened the clinic, the end is overall historic is before becomes make a difference treatment.
Repeating in PT exactly what.
Yeah. So there is using blood the number of these two. And prove again if you have more than 5 CDs for patients who develop metastasis, much more aggressive disease. Doesn't the disease respond to treatments. Trying to find out is that one of the published ICU last year showed they have and they are perceived in 2 weeks change to another that will not have any why for the one that had. So I think what it says there are two perspectives what they say are to test because it's very important. Better market to disease that have in is need to test it's not progressing. If it's not down for the imaging set, that's very actually flow. So it's important because we have a way to monitor to understand the disease at a different level. Now the next step everybody working is trying to get mutations to eliminate the CT. So there is that response. I don't know if it's
these questions coming fast, furious. Someone did ask if the PowerPoint would be available, and yes, it will be. Live streaming. Questions are our web, but you will be org look stream to check on what you heard and formulate on healthcare provider. You can do that. Someone, and going back to genetic testing, is there an where you should have your
no, as an scientific age, you need to think about you have a risk. You don't want to go teenagers and enjoy testing because guys, young girl, we want to wait at monitoring strategy include them because they too worried what be prophylactic interventions. You know, have to be careful in the way we increase information. Too much information at the wrong time.
And she's had reconstruction after. In her follow-up visit, what
breast tissue is completely removed. Depends on the original start with. We may want to for the lymph node that we just example. In general, is more of a physical follow-up.
very good. We have time. And it's so hard to pick, but is should we organic food? Research on
well, organic food is be used in particular meat. Hear about poultry, supplements and so forth. You should provide that this is remain to be seen. One able to monitor in a way how this different diet possibility to develop environmental factors that we know be that, but the tumor
so much for questions. Thank you all for your questions. I bet to you. Fabulous questions. Our closing, we'll come back with the day we will some of those that you're all concerned. So thank you, and we see you back.